Hi. Today we'll discuss the last part of the patient assessment, which is the examination of the dentition. The examination of the dentition is considered by the patient is the most important part of the assessment because that's what the patients came for the dental clinic because they have actually a dental problem. So in the process of the tooth examination, it involves several steps. We need to go through them, as we said earlier, systematically from the first part, which is the visual inspections, and then we go through more specific part like the radiographic examination and provision of study casts. In the process of the examination, we start with the visual inspection, as we said earlier. The teeth needs to be dry and clean. The operator needs to have a good light source and needs a dental mirror to perform the visual inspection for the dentition. Probing can also be done by a sharp explorer. This is a controversial subject because some might consider using a sharp probe a way to break the surface of the enamel, and then this might accelerate the process of the dental caries. We also can perform percussion. Percussion would be different from what the medical practitioner might do. Percussion within the dental practice can be done within the handle of the dental mirror. We also can palpate the piratical area with a gloved finger. We can test the pulp by different means. For example, we can use an electrical pulp tester. We can use a thermal pulp tester by either using a heated guttapercha to examine the pulp vitality, or use cold ethyl chloride on a cotton plate just to examine the response of the pulp to thermal changes. Radiographic examination can be also used, and study cast. These are the instruments that we usually use for the purpose of the patient dentition examination. We have the college tweezer, a periodontal probe, a sharp explorer, and a dental mirror. This is an ethyl chloride, a cold spray. We have also a piece of sterile gauze, cotton rolls, and the three-way syringe. All the instruments, as you can see here, are packed and have been sterilized using an autoclave. The three-way syringe have a disposable tip here on it, and a plastic sleeve just to cover the handle of the three-way syringe. During the examination, as we said, the teeth need to be dry and clean. For example, if we have patients who have a dentition like this with significant amount of a plaque on it, it's best to delay the examination of dentition until the patient have removed this plaque, for example, by simple scaling and polishing, and then we schedule the patient for another appointment for the assessment of the dentition, because there might be pockets around these teeth. The plaque might make it difficult for it to be assessed. There might be a carious lesion beneath those plaque. Okay, we also need to remove the plaque in the first instance, and then we can get a visual inspection, a proper visual inspection for the dentition beneath. Removable prostheses, if the patient's wearing denture, removable dentures, for example, partial or complete dentures, these needs to be examined in the first instance within the oral cavity, and then we ask the patient to take them out. We examine the prosthesis itself and examine the area just beneath the prosthesis. Restorations, if the patients have amalgam restoration, composite restoration, we usually examine, visually inspect the margin. If there is any discoloration, if there is an obvious fracture of the restoration, we also sometimes we use a probe to probe the margin of the restoration. If the teeth have an extensive restoration, a large restoration, and they are symptomatic, we might consider examine the pulp vitality. We might also take a radiographic examination for them. Okay, so eventually any restorations within the oral cavity need to be examined as part of the dentition. Vertical and horizontal percussion. Percussion, as we said, in the dental practice can be used with the handle of the mirror. As you can see here, this is the handle of the mirror delivering a vertical force along with the long axis of the tooth. This is a canine, and the operator is using the handle to deliver a force on its cusp tip. This is a vertical percussion, and this can be used to assess if there is any abnormalities within the apical periodontium. So if there is anything related to the apex of the tooth, this can be assessed using a vertical percussion. On the other hand, we also have a horizontal percussion. If you see, this is the handle of the mirror delivering a force that is perpendicular to the long axis of the tooth. This can be used to assess the marginal periodontium, the periodontium that is around the tooth rather than being on the apical part. Okay, this is a horizontal percussion. So horizontal percussion for the marginal periodontium, and an vertical percussion to assess the apical periodontium. We also can use palpation for the periapical area. We can use a gloved finger just to palpate the area around the apex of the tooth, and if the patients have any pain or tenderness, these need to be addressed. Sometimes if there is an acute inflammatory process with severe pain related to the apical periodontium, simple application of a digital pressure by a finger in the direction of the long axis of the tooth, sometimes this can elicit pain and can be recorded within your notes. In addition, during the palpation of the periapical area by the means of the gloved finger, as we said earlier, if there is any swelling, fluctuation related to the apex of the tooth, it can be felt by the operator's finger and can be recorded as well. All of these notes need to be recorded by either the operator after he has just finished, he or she finished the examination and taken off all the gloves, or can be done by the dental assistant. So we can ask the dental assistant to record all these notes just to make sure we maintain the asepsis of the dental record. So we make the dental record, we keep the dental record clean. We can't just touch the patient and then we go to our dental records and put them in the notes, because this might carry a risk of infection being carried from the patient to the dental record and then to anybody who deals with these records. Within this slide, we're going to discuss about the diagnosis of the infection and inflammation related to the dentition. In the first instance, we're going to review the parts of the teeth. We have the enamel, the dentine, and of course the pulp chamber, which contains all the neurovascular bundle that innervates and nourishes the tooth. We also have this radicular pulp, and we have the periodontium that supports the tooth within the jaw. In the first instance, we have a carious lesion that involves the enamel and advanced into within the dentine. From the bacteria, the products might irritate the pulp, leading to an inflammation of the pulp, which is referred to as pulpitis. The pulpitis can be either acute or chronic. Sometimes, within the prolonged duration of the inflammation, pulp gets necrotic. And then we have issues that related outside the tooth. So following the pulp necrosis, there is a response of the periodontium, response of the body to contain the irritation from the necrotic tooth or even an infected pulp. Okay? Within time, this inflammation within the periodontium might really lead to the development of an abscess, and then it will lead to bone resorption and sinus discharge outside the bone. We're going to take this part by part. The first part is the pulpitis. Pulpitis can be either acute or chronic. All what we can see by visual inspection is a carious tooth. Okay? Patient with an acute pulpitis, those considered the most emergencies within the dental practice. Okay, most of the patients in our dental practice who seeks dental treatment due to pain might have an acute pulpitis. The characteristic of the pain is usually of the severe or throbbing pain that is about minutes in duration and usually stimulated by thermal changes or sweat. As we said, the duration of the episode is about minutes, so it might be for about 10 minutes. On the radiographs, we can't see anything apart of the cause, which is usually an carious lesion. Patients having acute pulpitis have different treatment options. It can be either pulpitis, can be either reversible or irreversible. Patients who have reversible pulpitis might get their symptom resolved following the removal of the caries and delivery of a dental restoration. Patients with irreversible pulpitis might either need an endodontic treatment to extirpate the pulp and have a proper endodontic treatment, or sometimes an extraction of the tooth. Patients, on the other hand, with chronic pulpitis have a pain that is usually dull, spontaneous in nature, and of long duration. It sometimes can reach hours. On the radiographs, same as with the acute pulpitis, nothing to be seen except having a carious lesion. Treatment option for chronic pulpitis would either include an endodontic treatment or extraction of the affected tooth. Following the necrosis of the pulp and then the irritation reach of the periodontium, we have a periapical inflammation. Periapical inflammation can be either an acute episode termed as an acute periapical periodontitis related to the apex of the tooth, apical periodontium, okay, and this is presented as also as a severe pain. Patients might give their pain particularly precipitated when the teeth came in contact, so it might be difficult to be localized by the patient. Either it is an upper or a lower tooth. But in general, acute periapical periodontitis is considered as a localized pain, while pulpitis is poorly localized because the periodontium has proprioceptive nerve fibers which allows the patient to localize the pain to the affected tooth. On the radiographs, the presentation of an acute periapical periodontitis differs from one patient to another. If there is no preceding inflammation, the acute periapical periodontitis is manifested as just loss of a lamina dura around the tooth, a localized bone destruction manifested by loss of lamina dura. If it is occurred in the area with a previous chronic infection or chronic inflammation, it might be manifested as an area of poorly localized radiolucency termed as rarefying ostitis. Management of an acute periapical periodontitis depending on the cause, because sometimes an acute periapical periodontitis might occur due to sometimes a trauma to an affected tooth. For example, for this patient, it has trauma before, splinting and time will allow healing for the tooth, for the periapical periodontium. Sometimes during endodontic treatment, irritation to the apical periodontium might cause an episode of acute apical periodontitis. Following the completion of the endodontic treatment within the tooth, then acute apical periodontitis during endodontic treatment will resolve by time. But if it is caused by a carious lesion or necrotic tooth, then endodontic treatment or extraction of the affected tooth will lead to the resolution of the symptoms. On the other hand, chronic periapical periodontitis, which is termed as periapical granuloma, has no presentation. Patients with chronic periapical periodontitis usually have no symptoms, but on the radiographs we can see either a widening of the lamina dura, okay, or sometimes a well circumscribed radiolucency for long-standing granuloma. The dimension usually for a periapical granuloma should not exceed 1 centimeter in diameter. If it is exceeded the 1 centimeter in diameter, we might suspect a periapical cyst or a radicular cyst rather than periapical granuloma. Management would include extraction of the affected tooth or an endodontic treatment to allow the healing of the periapical granuloma. Another inflammation that's related to the teeth and jaws is the pericoronal inflammation or pericoronitis. Pericoronitis, it's related to the soft tissue flap that covers a partially erupted teeth or impacted teeth. This is termed as the operculum. And if the patient has a partially erupted tooth that covered by this soft tissue flap, the operculum, have an area that haven't been maintained properly, it might get damaged from the opposing tooth. For example, this is a lower third molar. If we have the upper third molar occluded on it, it might be lacerated, and there is a food debris around it, it becomes secondary infected. An infection within this is termed as pericoronitis. It's usually associated with a pain. Patients might be given pain that is localized to the pericoronal flap. In severe nature of it, patients might develop trismus, which is limitation of the mouth opening, so the patients can't open their mouth widely. In some instances, facial swelling is also associated with severe form of pericoronitis. In chronic pericoronitis, pus discharge might also occur around the pericoronal area. On the radiographs, we can't see anything apart from, because it's related to soft tissue, so we can't see anything. But some would see this, which is a partially erupted tooth, which might suggest that there is a pericoronitis. Also, in long-standing pericoronitis, there might be enlargement of the space that surrounds the tooth. So there is enlargement of the pericoronal space. We also sometimes have this densification of the bone next to the pericoronal space, which is termed as condensing ostitis. Management of the pericoronitis would include irrigation of just the area beneath the soft tissue flap with chlorhexidine wash. Also, we can use normal saline just to maintain the area clean beneath it. We ask the patient to maintain better oral hygiene, and sometimes we need to grind from the opposing tooth to prevent further damage of the operculum. We schedule the patients for another appointment, and then we assess the need for either removal of this soft tissue, operculectomy, we remove the operculum, or sometimes we extract the tooth, depending on its prognosis. Dental infections. There are certain situations that can result into dental infections. Dental infections can also be classified either as an acute dentoalveolar abscess or chronic dentoalveolar abscess. An acute dentoalveolar abscess can be caused by either a periapical periodontitis, a periodontal disease, pericoronitis, or an infection within the cyst of the jaw. So teeth with periapical periodontitis, if develops an acute dentoalveolar abscess, will usually be tender to palpation, to simple palpation. They are necrotic, so give negative response to, for example, cold test, and the area surround them might be also, if we palpate the periapical area that related to a teeth that has pre-existing periapical periodontitis and then develops into acute dentoalveolar abscess, the area will be tender to palpation. And following the abscess being moved from the periapical area into the bone, and then if it's perforate the cortex, we will have a fluctuant swelling related to the apex of the teeth. The teeth is also tender to vertical percussion, as we said. Periodontal disease, on the other hand, the teeth usually will be vital, okay, mobile, and also tender to horizontal percussion. And the dental abscess, rather than being related to the apical region, it's mostly related to the marginal, next to the gingival sulcus. Pericoronitis, a chronic pericoronitis, can result into development of pus, and acute dentoalveolar abscess might occur. If we have a cyst within the jaw, it might become secondary infected, and an acute dentoalveolar abscess might happen. These are the presentation for patients with the dentoalveolar abscess on the radiographs. Because we have different scenarios, we have different radiographic finding. For example, if there is an acute periapical periodontitis and then it's developed into an acute dentoalveolar abscess, will nothing to be seen on the radiograph apart of destruction of the lamina dura. If we have a chronic periodontitis that have been developed into acute dentoalveolar abscess, no, we will have the pre-existing well circumscribed radiolucency will lose its this distinction mark and become as a rarefying ostitis, a poorly defined radiolucency. Same would be applied for the cyst. So the cyst, in the beginning, it has a well demarcated line. So we have a radiolucency that is surrounded by well circumscribed radio-opic line. Okay? If we have a dentoalveolar abscess, we will lose this distinctive line and then become a poorly diffused radiolucency. This is the radiographic findings for patients with a dentoalveolar abscess. The management would depend on the prognosis of the tooth and the cause of the dentoalveolar abscess, but eventually it can be either, for example, for patients with periapical periodontitis, the management would include either extraction or endodontic treatment. For patients with periodontal disease, which might require periodontal treatment, pericoronitis needs to be addressed, as we have said earlier, and if it is a cyst, it might require surgical intervention to remove the cystic lesion. All these interventions need to be taken following the management of the acute phase of the infection. Within time, if the acute dentoalveolar abscess haven't received the proper treatment, it will develop into a chronic dentoalveolar abscess. So there will be a sign of discharge marked by a parudis or a gum boil next to the target tooth, and it will discharge the pus occasionally. The patient will have a dull pain or mild symptoms that might be exacerbated by, for example, by biting, but is mild in nature when compared to the acute. And once this discharge have been blocked by any means, the chronic dentoalveolar abscess might revert back into an acute abscess, and it's termed as an acute exacerbation of existing chronic dentoalveolar abscess. This is all what we have for today. If we have any questions, please leave them in the comments. I will be more than happy to answer them. Thank you.